Director Yee,
Present.
Director Stewart,
Present.
Director Epen,
Present.
Director Wallace.
This conference is being recorded.
Present.
Only the main conference is recorded.
Very good. And Dee, if you could tell us who's in the boardroom with you?
Yes, here in the boardroom, Kimberly Hartz, Ed Fayen, Chris Henry, Tina Nunez, Stephanie Williams, Paul Kozachenko, Shri Bodu, and me, Dee Antonio.
Thank you, Dee. So welcome to the April 14th, 2021 regular meeting of the Washington Township Healthcare District Board of Directors. To comply with Alameda County's order number 2101 as issued on January 25, 2021, to comply with social distancing measures and other restrictions necessary to control the spread of COVID-19. This meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. Governor Newsom's executive order number N 2920 explicitly waives the Brown Act provision that requires the physical presence of members, the clerk, or of the public as a condition of participation in or quorum for a public meeting. We continue to comply with the Brown Act in providing dial-in information in order to provide the public the opportunity to attend the meeting. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. We'll now move to the communications section of our agenda. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none. Dee, do we have any written communications?
No, we do not.
Very good. We'll now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Hearing none. Does any member of the public want to remove an agenda item from the consent calendar? Hearing none. May I have a motion to approve the consent calendar items A through E?
Mr. President, in accordance with the district law, policies, and procedures, I move that the Board of Directors approve the consent calendar items A through E.
Thank you. Do we have a second?
Second.
Okay, second from Director Stewart. Dee, can you call the roll?
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen,
Aye.
Director Wallace.
Aye.
Great. Consent calendar passes. We'll now move on to our presentation. Kimberly, if you could introduce our speakers tonight.
All right, thank you very much. I am pleased to introduce two speakers this evening. The first I'd like to introduce is Dr. Jeffrey Stewart, that I think all of you know him well, but Dr. Stewart currently serves as Chief Medical Officer for Washington Hospital, where he's been a member of the medical staff since 1994. Prior to this role, Dr. Stewart, an anesthesiologist, was the medical director of Washington Outpatient Surgery Center for 14 years. Dr. Stewart also serves as a surveyor for AAAHC, the Accreditation Association for Ambulatory Healthcare. I also like to introduce Dr. Stephen Catalia. He joined Washington Township Medical Foundation in August of 2020 as an internal medicine specialist with a special focus on infectious disease. He currently picked a compelling time to become part of our team. Before coming to Washington Hospital, Dr. Catalia was an infectious disease fellow and consulting physician at 4 hospitals in the Mount Sinai Hospital System in New York City, a place many have called the epicenter of America's coronavirus pandemic. Besides being at the forefront of COVID-19, the physician researcher has extensive experience in skin, soft tissue infections, malaria, travel medicine, tuberculosis, non-tuberculosis, mycobacterial infections, endovascular infections, central nervous system infections, and HIV/AIDS. A Bay Area native who grew up in Walnut Creek, Dr. Catalia is happy to be part of the Fremont community, a diverse, multicultural environment that's a perfect fit. So I think, Dr. Stewart, are you going to begin?
I am. I did a good job muting myself. Can everybody hear me now?
Yeah.
Yes.
Great. Excellent. Yes, well, thank you, Kimberly and Dr. Nicholson and the board. It's great to be able to be here and speak briefly. Dr. Catalia and I have actually given talks together a couple times already, so we're all warmed up for the primary audience here, so this should go well. And really the plan is I'm going to just briefly talk about the overview of the vaccine rollout, our own vaccine rollout, but just generally in the county, and a couple comments overall, and then Dr. Catalia will go into a little more detail as far as the specific vaccines. I know the Johnson & Johnson issue is the forefront of everyone's minds, and just kind of dovetail into just what is everything that's going on now with the vaccinations and otherwise mean for how we can live now and what we're going to be looking forward to in the coming weeks and months. So that's the general overview. So we can go to the next slide, please. Thank you very much. So this slide, as well as the next one, I'll show you, come from the Alameda County Department of Public Health website. As I think all of you know, we've worked very closely with the county with respect to our entire pandemic response, but with respect to the vaccine, especially, we've been meeting for months now with within ourselves and with the county. So it's really been a great partnership, and we've gotten to know a lot of the personnel there better. And I think it will be, just as an aside, a real positive going forward to have these relationships. And as far as the eligibility, which was kind of the hot topic on vaccines changes day to day, but that was a hot topic for quite some time. But as I think everybody is aware now, just this week, Alameda County and the entire state on the 15th tomorrow will be going to the level of where everybody ages 16 and over will be technically eligible for the vaccine. As we all know, that doesn't mean everybody will be getting vaccinated this week that's 16 and over, but it does mean everybody's eligible, and that it really kind of simplifies the entire tier system that changed day to day and sometimes hour to hour. So we are in a great place as far as eligibility. And just briefly, while I would say that from what I have learned from my talking to people at the county and being on a call today, while and again, Dr. Catalia will talk more details about the side effects and the issues with the Johnson & Johnson. But as far as the availability and the pause of it, it should not affect things too dramatically in our county and our state here in the next week or so. We were already factoring in a decreased supply of Johnson & Johnson based on some of the manufacturing issues they'd had. So I just want to reassure everybody on that. I don't think it's going to be a huge step back. The general, again, Dr. Catalia will speak more, but the general consensus from those I spoke with today that I think were privy to more discussions with the state and maybe federal representatives felt like this was going to be a pause to be safe and to look into the individual cases and the specific side effects and probably come up with some new guidance, but they did not feel like this was something that was going to eliminate Johnson & Johnson from the equation. So it's not clear yet, but I am hopeful, and as everybody I talked to today, that they will figure this out and being very safe, appropriately so, and we'll talk about that a little bit more in a bit. One thing I would mention on this, as some of you may know, there are studies going on as we speak in children with respect to Moderna and Pfizer vaccines. And Pfizer actually presented, their data has already been presented or made public with respect to adolescents. I believe it's age 12 to 15, and they are in the process of applying for emergency use authorization with the FDA for that. So it could be that in the near future, the Pfizer vaccine will be approved for adolescents as well. So I think this is what we're going to be seeing from the vaccines that are already approved as the testing in adolescents and children progresses here over the next several weeks. Next slide, please. Thank you. And this is, there's a lot of great information on our website primarily, but also on the county website, I will say. And if you go to the COVID-19 area of the website and you dig around a little bit and under vaccination, there's a lot of interesting information. This is just kind of a summary slide, which kind of gives us an overview of Alameda County. As far as you can see, over 1 million vaccines have been administered. And then the numbers with respect to at least 1 dose and fully vaccinated. And this roughly translates into, as far as the eligible, 16 and over population, a little bit over 50% of Alameda County has had at least 1 dose of the vaccine. And just over a third of the population has, these are approximate percentages, are fully vaccinated. So it's really, having been involved with this from the beginning and sitting there in December, not knowing what day we were going to get our first vaccine, to now we are really not so many months away from that. And the progress we've made, while there's still a lot of work to be done, is really impressive. And as you'll see on the next slide, a lot of the progress here has been due to the efforts at the hospital. So if we could please have the next slide. Thank you very much. So this really shows the volume. Is even more we could add on after we have, this is a day or so old, these numbers. Basically almost 40,000 vaccinations we've given and vaccinated, over 20,000 people, close to 23,000 people probably are at that now. And that's a real testament to all the time and hard work and dedication that so many people have put in on all levels of the hospital and the hospital system. And it's really been an incredible team effort, and the resources that have been needed, both physical and personnel wise, have really been impressive. And the hospitals really come through for our patients and the community. And this is something that is, we're not planning on stopping anytime soon. So we'll be excited to, as we go along here over the months, come back and give further updates as to larger numbers here. But this is this really is something that, as I know anybody that's been by the hospital has seen the folks going to the vaccine clinic. And then, as you'll also see on the next slide, please. We have also done work out in the community. This is, again, as the community district hospital, we really are dedicated to serving the entire community. And we were proactive and with a lot of these businesses in going out and bringing the vaccine to them. We've done this on smaller groups, a couple of rather large groups, as you'll see on the relationships that are listed here. And we continue to plan on doing that and seeking out, especially areas that are hard to get to with as far as getting people vaccinated and on board, and really trying to, we've been in lockstep with the county from the beginning as far as equitable distribution of vaccines, and really trying to live that mission that the county's trying to serve. And I think I'm sure the county would agree that we've been a great partner with them, and really are focused on continuing to do this, as I've said. And just before I turn it back to Dr. Battaglia, we can go to the next slide, please. And this just kind of is the theme. Yeah.
I had a question on that.
Sure.
I know in the past we've had difficulty with supplies, that it's been unreliable and difficult to get. How are we doing on that? Are we pretty much secure week to week on what we're getting?
Well, I guess, I mean, what's interesting is I could say we are secure week to week, but we are still kind of week to week, if that makes sense. And that we've been very steady, and as far as what we're getting. And yet we do have to request every week and submit some charting and data on what we've given, what our capacity is. We do seem to have hit a steady state and have not had issues. Again, The Johnson & Johnson threw a little bit of a curveball, but I would say with respect, our efforts are primarily Pfizer. We had given some Johnson & Johnson, just as an aside, and we were really planning on trying to roll that out primarily, and again, per the state and county guidance, to use on our inpatients. And a lot of work's been going on with IT, nursing, everybody, as far as trying to make a safe plan for that. And in the midst of being about ready to roll that out, that's when this news came down on the Johnson & Johnson. But I would say we are confident, very confident in the supplies we're getting week to week. But the downside, if I'm being honest, is that we don't have a chart of like the next month's supplies, I should say. So it's in that respect, it is a little bit stressful, but we have a lot of track record behind us, I would say, as far as being supplied. And our communication, we communicate with the county several times a week. As I know the board members know, and others might be aware, that we will be switching here eventually, going through the third-party administrator, Blue Shield, as far as the vaccine supply, as opposed to the county. But a lot of the things that have happened behind the scenes with the county having a memorandum of understanding with the state and Blue Shield with respect to their input as to the supply of vaccine, we really feel like, even though the process maybe exactly of who we get the vaccine delivered from might change, that we're confident our supply is going to be kept up. I think the reason for that is because we've been able to deliver on giving the shots with the vaccines we've had supplied to us. So I think that's great, but I think, as I said, we don't have a month-to-month schedule of supplies. It is pretty much week to week or every 2 weeks. So we basically, we do need to continue to do that, and that's what we plan on doing. So I hope that answered your question. It's kind of, we are secure, but we aren't. We are always looking every week to make sure we have the amount that we're planning on.
Thank you very much. I am really, really relieved that it's secure week to week. I think that's more than what we were for a while.
Right, and I'm knocking on wood literally as I'm saying that, because I don't want to jinx us, but that is the case. And again, we really have deep relationships with the county. They know we're delivering on what we can do, and there's been no indication that as we transition to the TPA, the third-party administrator, that will be affected at all. So we certainly are hopeful that's the case, and that is what we're planning on. We've been quite proactive, actually, like as far as seeing things coming down the road and really staying ahead of it. So I think that also plays to our favor. And with that, I think, and we can take more questions at the end. And I'm sorry if I took up, Stefan, more time than I was planning on, but let's turn it over to Dr. Catalia now, and he can talk a little bit more about the details of the vaccine, the disease, and what we are going to be experienced here now and in the near future. So Dr. Catalia, I turn it over to you.
All right, thank you, Dr. Stewart. And thank you everybody for attending tonight. And I guess we'll just wait for my slides to come up. But definitely a lot to talk about tonight with both the vaccine rollout and the late breaking news yesterday about the Johnson & Johnson vaccine, and also basically where we're going forward with the state of the pandemic. All right, just let me know when you're ready, but yeah, that's the title card. And next slide, please. So we'll be starting off with the different COVID vaccines. And currently the slide says that there are 3 vaccines. It should be *3 vaccines in circulation here in the US to stop the spread of COVID-19. We obviously have been having the Moderna vaccine and the Pfizer-BioNTech vaccine, both of which are messenger RNA based and requiring 2 shots since December. And then the Johnson & Johnson vaccine, which technically is still in circulation, but as of yesterday, obviously the CDC and the FDA recommended that there be a pause in the distribution of the vaccine while it gets reevaluated. And there are also 2 other vaccines that are in different stages of development. The AstraZeneca vaccine, which is a DNA-based vaccine requiring 2 shots, that has generated a lot of discussion in the news over the last few weeks. And then the Novavax vaccine, which as per some news reports and as per Dr. Fauci, might get FDA authorization for distribution in May to June of in the next month or so. But next slide, please. So in terms of, but for this talk, we'll be focusing more on the vaccines that we have been distributing, and that would be the Pfizer, Moderna, and Johnson & Johnson vaccines. So in terms of Pfizer vaccine efficacy, in terms of preventing COVID-19, at least 7 days after the second dose, it was found to have a 95% efficacy, and that was in a study with 38,000 participants. They found that there were 8 COVID cases in the vaccine group and 162 in the placebo group. The Moderna vaccine also had a very good efficacy in preventing confirmed COVID-19 cases at least 14 days after the second dose, and that was a 94.5% efficacy with a 30,000 participant study. They found 5 COVID-19 cases in their vaccine group and 90 in the placebo group. Meanwhile, the Johnson & Johnson vaccine efficacy was about 67% when considering cases occurring at least 14 days after the one and only dose of the vaccine. In the vaccine and placebo groups, respectively, there were 116 cases and 348 COVID-19 cases occurring at least 2 weeks after the vaccination. The one thing to keep in mind, though, with the Johnson & Johnson vaccine efficacy is that it was tested in areas that were known to have the South African variant, whereas the Pfizer and Moderna vaccines were not. Next slide, please. And in terms of the side effects, starting off with the messenger RNA-based vaccine. So for Pfizer, the most common one was an injection site reaction. Think of it as arm pain that occurred in 84% of recipients. And that was followed up with fatigue, headache, muscle pain, chills, joint pain, and fever. The severe reactions occurred in less than 4.6% of participants in these trials. It was more likely to occur after the second dose, less likely to occur in individuals older than 55, and it occurred in less than 2.8% in that group compared to younger participants, and that was less than 4.6% participants. But Pfizer considered that all of those side effects were transient and manageable. For the Moderna vaccine, similar to the Pfizer vaccine, the most common reaction was injection site pain, occurring in more than 90% of those who received the Moderna vaccine, and then followed up again by fatigue, then headache, muscle pain, then followed up by joint pain and chills. Severe reactions occurred in the Moderna vaccine trials at 0.2 to 9.7% of participants. Again, more after the second dose. Again, less frequent in the older population. For Moderna, they define it as older than 65, compared to Pfizer, which is older than 55. But again, compared to younger participants, it was less frequent in the older populations, the older cohorts. And similar to Pfizer, the Moderna vaccine side effects were considered to be mild to moderate in severity. Next slide, please. And then for the Johnson & Johnson vaccine, starting off with what was reported in the trials, the most common reaction again, or most common adverse effect, was injection site pain. But note with the Johnson & Johnson trial, it occurred in less than 50% of people. And that was followed up by headache, fatigue, and myalgias, again, similar to muscle pain. But all of these were considered to be mild and moderate. Again, similar to the other vaccines, it was less in the older populations, less common in those who are above 60 years old. And again, most resolved after 2 days. But as we've seen in the news recently, there have been other adverse effects that were reported that were not in the trials. Specifically, as we all saw in the news yesterday, there were 6 reported cases of central venous sinus thrombosis and thrombocytopenia, basically low platelets. And all 6 of these cases were found to be in women between age 18 and 48 years old. And the common symptoms that they had were headache, leg pain, abdominal pain, and shortness of breath. And these occurred within 6 to 13 days of having gotten the Johnson & Johnson vaccine. And that led the FDA and CDC to, quote, recommend a pause in the use of the vaccine, end quote, yesterday. The FDA and the CDC didn't have a meeting today, but as of right now, the pause in the use of this vaccine is still in place. Next slide, please. And then talking about the AstraZeneca vaccine, which is not in distribution here in the US, but has generated a lot of discussion in the news. This is different from the Pfizer and Moderna vaccines, and is also different from the Johnson & Johnson vaccine. It is a DNA-based vaccine, similar to the Johnson & Johnson vaccine, but this one enters human cells, introduces DNA to muscles, it makes a spike protein, and it triggers an immune response. This is developed in collaboration with the University of Oxford and AstraZeneca. According to data reported by AstraZeneca, it was 76% effective against symptomatic COVID-19 and was 85% effective for those aged 65 and up. AstraZeneca claims that it is 100% effective against critical disease and hospitalization. It has been distributed internationally, including Canada, the UK, and the European Union. However, it has seen its problems as well, as multiple countries have suspended its use at different times during the vaccine rollout. There has been a link between the AstraZeneca vaccine and very rare episodes of blood clots in the brain. But according to the EMA, the European Medical Agency, the link has been explored, but possible causes are still unknown as per the EMA. There is a concern about the AstraZeneca vaccine as it relates to the South African variant, which we'll talk about more later on, along with the other variants, but is effective against the other COVID-19 strains. Next slide, please. Talking now again about the sort of the frequently asked questions about the vaccines that a lot of us have received over the last few months and will probably continue to receive. So first, are the vaccines safe? And I've actually had to update this to say that the Moderna and Pfizer vaccines have gone through rigorous studies to ensure that they are as safe as possible. This includes meeting safety criteria met by both the FDA and CDC, not just safety criteria that was created by Pfizer and Moderna. That is to say, it meets safety criteria set aside or created by independent agencies. The Johnson & Johnson vaccine, as I touched on earlier, is being reevaluated as of yesterday and still continues to be reevaluated as of right now. If a person got COVID-19, do they need the vaccine? And these are questions I have been asked in both an inpatient and an outpatient setting. And the answer is yes. Due to risks of COVID-19 and reinfection, the COVID-19 vaccine is still needed. In terms of when a person should get the vaccine, that part gets a little bit trickier. If your treatments included monoclonal antibodies, like bamlanivimab or Regeneron, or if you got convalescent plasma, then the CDC recommends waiting a minimum of 90 days before getting a COVID-19 vaccine. If a person did not get get monoclonal antibodies or convalescent plasma, then it becomes more of a clinical decision as to when a person should get the COVID-19 vaccine. So what we've been saying to patients is, talk to your doctor if you're not sure about what treatments you received when a person did get infected with COVID. Other questions, can I get an allergic reaction with the COVID-19 vaccine? Allergic reaction, serious problems from vaccination can happen, but they are pretty rare. As we've seen, even going back briefly to the Johnson & Johnson vaccine, there were those 6 patients, but that's 6 cases out of 6.8 million doses that have been given here in the United States. And next slide, please. In terms of, can I get the COVID-19 vaccine at the same time as another vaccine? Ideally, no. We've been recommending, and the CDC has been recommending, to wait at least 14 days before getting any other vaccine, including the flu vaccine or the shingles vaccine, if you got the COVID-19 vaccine first. And if you got another vaccine first, we recommend to wait at least 14 days before getting the COVID vaccine. That being said, if a vaccine is inadvertently given within 14 days of another vaccine, you don't need to restart the vaccine series, you just keep going. If I am vaccinated, can I still get COVID-19 or spread it to other people? The answer is yes. Vaccine trials show that a very small % of people were still getting COVID-19, but their symptoms were less severe. And yes, you could have 0 symptoms and still spread the virus. Next slide, please. So obviously, another question that's been asked a lot is, can a lady get pregnant or get the vaccine while pregnant or breastfeeding? And the answer is pregnant people in a group who are recommended to receive the COVID-19 vaccine may choose to be vaccinated. The slide there says healthcare workers, etc. But as we've seen with the vaccine rollout, we've obviously expanded that now to just beyond healthcare workers. But yeah, the short answer is that it's a clinical decision, and we recommend that a pregnant lady talk to their doctor if they have any other concerns before getting the vaccine. There are no data that are available on the safety of COVID-19 vaccines in lactating women or on the effects of messenger RNA vaccines on breastfed infants or in milk production or excretion. Messenger RNA vaccines, that is the Pfizer and Moderna vaccines, though, are not thought to be a risk to breastfeeding infants. The CDC in the last few weeks did publish some surveillance data regarding female healthcare workers who did get the vaccines, and they showed that they were able to pass on antibodies to their newborns. In terms of fully vaccinated, that's obviously a term that's been thrown around for the last month now as people try to go back to a sense of normalcy and traveling and meeting up with other people. So in terms of what fully vaccinated means, that's 2 weeks from when you got the last dose of the vaccine. So for Pfizer and Moderna, it's 2 weeks from when you got the second dose. For Johnson & Johnson, if you got that vaccine, it's 2 weeks from the one and only dose of the Johnson & Johnson vaccine. And that's the amount of time that's considered to be needed for the vaccine to take full effect. Next slide, please. Once I get the vaccine, do I still need to wear a mask, socially distance, and wash my hands? And the answer is yes. So unfortunately, this pandemic is going to continue until we get the herd immunity. You can still spread COVID-19 even if you are vaccinated and have no symptoms. That being said, the CDC has released criteria to say that if you've been fully vaccinated, you are allowed to gather indoors with other fully vaccinated people without a mask. You can gather indoors with unvaccinated people from one other household. That is, for example, visiting with relatives all live together, and that can happen without masks unless any of those unvaccinated people or anyone they live with has an increased risk for severe illness from COVID-19. Also, if you've been around someone who has COVID-19, you do not need to stay away from others or get tested unless you have symptoms. That being said, there is a caveat to that. If a person lives in a group setting like a correctional facility or detention facility or a group home, and they are around someone who has COVID, they still need to stay away from others for 2 weeks and get tested, even if they don't have symptoms. Next slide, please. So in terms of traveling, because obviously, like as we start to see people get fully vaccinated, people want to get out. We've seen a lot of commercials now for traveling and everything. So basically, people who are fully vaccinated can travel safely within the United States. That was a statement put out by the CDC about 2-3 weeks ago. Fully vaccinated travelers do not need to get tested before or after travel unless the destination requires it, and they do not need to self-quarantine unless the destination requires it. Fully vaccinated travelers, though, should still follow recommendations for safe traveling, including mask wearing, covering both the nose and the mouth, not one or the other, both. And you also need to stay 6 feet away from others and avoid crowds as much as possible. And then also wash your hands often or use hand sanitizer. And then after travel, the CDC recommends that persons still self-monitor for COVID-19 symptoms. And if they get symptoms, they need to isolate and get tested. I also recommend to follow all state and local recommendations or requirements. That being said, you do not need to get tested or self-quarantine if you are fully vaccinated or have recovered from COVID in the past 3 months. You should still follow all other travel recommendations, however. Next slide, please. Thank you. In terms of unvaccinated travel, CDC recommends that before traveling, a person who's unvaccinated get tested with a viral test 1 to 3 days before your trip. While the person's traveling, again, mask wearing, avoiding crowds, and staying at least 6 feet from anyone who's not traveling with you, and then practicing good hand hygiene, washing hands, using hand sanitizer. After traveling, that being said, get tested with a viral test 3 to 5 days after travel, and stay home and self-quarantine for a full 7 days after travel, even if that test is negative. If the test is positive, then obviously that person would have to isolate to protect others and also to from getting infected. If you don't get tested, then the CDC recommends staying at home and self-quarantining for 10 days after travel, and then avoid being around people who are at increased risk for severe illness for 14 days, whether you get tested or not. And then obviously self-monitor for COVID-19 symptoms, and then isolate and get tested if you develop symptoms. And of course, follow all state and local recommendations or requirements. Next slide, please. And then now talking about the variants, because that's obviously another thing that's been generating a lot of discussion in the news and in the scientific community. We obviously are aware that viruses constantly change through mutation, and new variants of a virus are expected to occur over time. Most variants of COVID are currently classified into 3 categories: variants of interest, variants of concern, and variants of high consequence. Next slide, please. So in terms of variants of interest, the CDC classifies these as specific genetic markers associated with changes to binding, that is like how well the virus binds to a person, reduced neutralization by antibodies from previous infection and vaccination. So think about it as like, a person who previously was infected with COVID, or they got vaccinated against COVID and formed antibodies. Those antibodies are not going to be as effective in neutralizing a variant. And then also there's a concern for reduced treatment efficacy, potential diagnostic impact. That is like a concern in terms of diagnostic testing, like the current diagnostic tests we have to pick up the variants. And then also a predicted increase in transmissibility and disease severity. Examples of this include the B1526 and 525. Those are the New York variant, and P2, which is found in Brazil. Keep in mind, this is not the Brazilian variant that has been talked about a lot in the news. That's P1, which I'll get to in a little bit. That being said, for variants of interest, the main concern with here is, again, the potential reduction in neutralization by monoclonal antibody treatments, and potential reduction in neutralization by convalescent, like post-infection and post-vaccination serum. Next slide, please. And in terms of variants of concern, these show an increase in transmissibility, more severe disease associated with increased hospitalization and death, a significant reduction in neutralization by antibodies from previous infection and vaccination, reduced effectiveness of the treatments and the vaccines, and possible concern for diagnostic detection failures. That being said, that includes here the UK variant, which is now the most common variant in the US. Note though that both Pfizer and Moderna have stated that their vaccines do provide good protection against the UK variant. Otherwise, the other variants of concern include the South African variant, which is being studied by all the different vaccine makers now in terms of possible decreased effectiveness, and the P1, which is the Brazilian variant that has been talked about, and the B.1.427, 429, which is the California variant. Concerns here include increased transmission, anywhere between 20% to 50%, increased transmission, significant to moderate impact on neutralization by monoclonal antibodies, as well as possible reduction on neutralization by convalescent and post-vaccination serum. Next slide, please. And then in terms of unclassified or high consequence, so the double mutant, which was talked about in the news last week, found in both India and California, it contains 2 mutations. And it's at the L452R, which is like in the E484Q. And those are like specific parts of the viruses like protein and like genetic code. That currently is not classified into any of the variants of interest or concern or high consequence as of right now, or as of last week rather. And in terms of variants of high consequence, that's the last one that's been last category that's been created by the CDC, and the CDC considers a variant to be of high consequence when there's clear evidence that prevention measures or medical countermeasures have significantly reduced effectiveness related to or relative to previously circulating variants. The good news is that there is no variant as of right now that falls into this category. Next slide, please. And in terms of the future of these variants and the future of the pandemic, so scientists continue to study these mutants while looking for new variants throughout the world. That being said, the vaccines given now, as per what Pfizer and Moderna have been saying, still provide protection against these variants. However, in the future, it is possible that a booster shot may be needed to protect yourself against the new variants. And the analogy I've been using is it's similar to how people are supposed to get a new flu shot each year, because the flu virus also does an excellent job of mutating, thus needing a new vaccine there. So, if we start talking in the next few months to next few years about needing a new booster shot for COVID, don't be surprised. Next slide, please. In terms of the recovery, because that's another question we've been asked a lot, the time to symptom resolution depends basically upon a person's pre-morbid risk factors, severity of the acute illness, and symptoms experienced. Symptoms such as fever, chills, and olfactory and gustatory symptoms like loss of smell, loss of taste, typically resolve within 2 to 4 weeks. That being said, fatigue, dyspnea, which is basically shortness of breath, tightness in the chest tightness, cognitive deficits, and psychological effects can last for months. The term that's been given to it is called post-acute sequelae of SARS-CoV-2 infection, abbreviated PASC. And symptoms there include fatigue, gastrointestinal problems, brain fog, inability to focus, depression, anxiety, sleep difficulties, and impaired lung capacity. Unfortunately, as of right now, while research is ongoing, the only care we available right now is supportive care. There's no, special medication. There's no magic pill that is used to treat these symptoms. Next slide, please. And in terms of when the pandemic is going to end, unfortunately, there's no clear timeline for when the pandemic will end. Sorry about that. Many things need to happen, and that includes achieving herd immunity. It's unclear how many people will need to be vaccinated. That's why we continue with this rollout. We do need vaccines that provide effective protection against all of the COVID-19 strains and all of the variants. Research is ongoing, and as of right now, we are saying that, the vaccines do protect against the variants, but the different manufacturers continue to look at it, and different public health agencies continue to monitor for new variants. We also need effective, easy to administer treatments. Pretty much all the medications they give right now are intravenous, that is into a person's veins. There have been some drug companies that have talked about a COVID-19 pill like molnupiravir that might be approved by the end of the year, but as of right now, everything is still given intravenously. And we still need acceptance of vaccinating and mask wearing and social distancing and hand washing. Unfortunately, we've had to fight uphill battles in all of those areas, which has led unfortunately to perhaps unnecessary hospitalizations and unnecessary death. Next slide, please. And in terms of what we can do to help, when the vaccine becomes available to you, and what we've been telling patients, when the vaccine's available to you and your doctor says it's okay to receive the vaccine, get the vaccine. Encourage others to get vaccinated if it is safe for them to do so. Promote and encourage respectfully, of course, mask wearing, hand washing, and social distancing. And if a person feels sick or if they have symptoms or signs, we've been telling them to quarantine immediately, call a doctor, and follow the doctor's instructions, as well as the guidance from public health agencies. And next slide, please. But thank you for your time. That's basically what I have to say. I know it was a lot, but thank you for listening.
Yeah, I know this question doesn't have anything to do with vaccinations, but what's the status of getting tested? It seems like it's more and more difficult to get a test anymore. So,
well, I mean, if you're symptomatic, it's probably easier, as you say. I mean, there are less, with respect, like RSTU is not, functioning now, but we still are testing anybody that's symptomatic that comes in our emergency room. And I would say there are a lot more ancillary sites in general that took some of the pressure off some of the hospitals, but you're right, you don't seem to see those as much. If you look at the summary data of how many people are being tested, that has certainly dropped lately as well with the drop in cases. But I do think, I don't know, Dr. Catalia, maybe you can add, but I do think that while it is less, that people are still able to be tested. And I know for symptomatic kind of screening tests, there's a lot of exciting stuff going on with respect to possibly of at-home testing. And I think even a couple of those were approved. But Dr. Catalia, do you have anything to add on that?
Yeah, I would say that it's still possible to get tested. I know the Walgreens on Maori, they still have the drive-through testing. I spoke with them about that yesterday. They also have the at-home test kits. Those are a bit pricey. It's like $150 per kit per person. Bay Area Community Health on, I believe it's Liberty Street, has testing available, but they're only, I think, Monday, Wednesday, Friday. And I think CVS's website still lists themselves as being able to do COVID testing. But in terms of what the turnaround time is, I'm not sure how that has evolved, but there are still places available to the public to get testing if they feel that it's needed.
Okay, thank you. I had another question about the booster shot. Assuming you had a Pfizer vaccination and you come next year and you're going to need a booster, would you have to stay with Pfizer or Moderna, or could you switch to Johnson because it's a different technology?
So that it's still too early to tell. Pfizer and Moderna, they're both working on the possible need for another vaccine in the future against the variants. I'm sure there are other pharmaceutical companies as well, but the criteria for mixing and matching is still being looked into.
Thank you.
Mike, to address your question on testing, one of the most common concerns for testing is people who need to travel, and that is available at the airport, and also apparently through Costco you can get a test which has a turnaround time sufficient to meet the needs of the airport and the airlines. I have a question for Dr. Catalia, and that has to do with which vaccine should a patient get? This is probably one of the most common questions that I get, and now with the question on the J&J vaccine, it'll be interesting to see how the CDC and FDA approach their decision-making on changing their current pause. But the question I have has to do with the apparent relative efficacy of the mRNA vaccines versus the J&J or the AstraZeneca. What do you think is the cause of that apparent difference in efficacy? And do you think there is any clinical difference in the efficacy, and should that drive a patient's choice? What I've been telling patients in the past is get the first vaccine that you can get. And the question now is, should that recommendation be changed?
Right. So in terms of the messenger RNA vaccines versus the Johnson & Johnson vaccine, the Johnson & Johnson vaccine was tested in an area known to have the South African variant. So there is the hypothesis that the Johnson & Johnson vaccine has a decreased effectiveness because it was tested in an area with the South African variant. The Pfizer and Moderna vaccines were not tested in areas known to have the South African variant. So it's possible that that's the reason why they have a higher percent effectiveness, and that if they had been tested in an area with the South African variant, maybe their percent effectiveness would have gone down. In terms of saying, Pfizer versus Moderna, I've been telling patients, whichever one between those two becomes available to you, then yeah, please get that one. Up until yesterday, I had been saying, if you get the Johnson & Johnson vaccine is available to you, then get that one also. Then you can get that one too. And we're obviously, still waiting now to see what the CDC and the FDA are ultimately going to say about the Johnson & Johnson vaccine as it compared to Pfizer and Moderna. So my response obviously has been tweaked in that regard.
I mean, if I could just add one comment, Dr. Nicholson, I would say that one thing that that I point out when I talk about this is also these vaccines were not only tested maybe in different patient populations, but there's been no trial testing one vaccine versus the other. So eventually I'm sure that will happen, and we'll get a real sense of, under common circumstances in a controlled experimental setting, how they compare to each other. So that's just one quick point to make. And my other point, which is when I go to a lot of people have heard me speak before, is that while these numbers on effectiveness relate to symptomatic, COVID, I think in most of the cases that's what we're referring to. When you talk about the real endpoint of hospitalization and death, all the vaccines available work against all the variants extremely well, maybe not quite 100%, but very close so far. And, personally, I think that's something that really needs to be stressed, because somebody might be otherwise healthy and 20 years old, but somebody may have multiple medical problems and be late 40s or 50 years old. And maybe the equation as far as risk benefit, as far as how urgent getting the vaccine will be is different, obviously, for somebody with comorbidities. And you could, now that it's getting complicated, where you might be as far as your exposure. So I just wanted to say those two quick points, but those are things I tend to discuss when people ask me about it.
Thank you very much for clarifying that. And it does appear to be an unfair comparison of the efficacy between the different vaccines because they were tested in different environments. The bottom line is that all of them are very effective against hospitalization, serious infection, and death. One last question is, what's your best guess is what the CDC and FDA are going to do in the next few days?
Wow. I'll let Dr. Catalia take that one, but I think from what I heard just from some people, at least that talk to people at the state, not that they really know, is I think they're going to take, I don't know that it'd be a few days. I think it might be a week or so. I think they're going to really look at it closely, but I don't think it's going to be a month, but I do think it's going to be maybe more than a couple days, but don't hold me to that prediction. And as to what they're going to do, I think some of what I heard was possibly have just new guidance around the vaccine. As you know, not to get too far out of this because I know we're running out of time, but some of it is just, even though these side effects of the clotting are extremely rare, it's almost like a heparin allergy kind of a situation. So they want people to know not to treat with drugs they might otherwise treat with. So that is extremely important, even though it is rare. But maybe Dr. Catalia has a better guess.
Yeah, actually, I pretty much agree with you on that. I think, it's not going to be, I would be surprised if they said tomorrow, oh, it's perfectly fine, go back. It's probably, I imagine they need to look at it for at least the next few days. If it takes another week or so, I wouldn't be surprised either. In terms of what's going to happen with the Johnson & Johnson vaccine, I mean, look, it's 6 people out of 6.8 million doses. So the events are pretty rare for this. That being said, again, like what Dr. Stewart was saying, they might wind up changing the guidelines in terms of who actually should be getting the Johnson & Johnson vaccine, who it's safe to give the Johnson & Johnson vaccine to. But, that's, again, my best guess too.
Well, thank you very much. I know it's really going out on a limb. I just hope that their decisions are data-driven and that they are transparent so that we can really understand the basis of those decisions. Well, I thank both of you for your wonderful presentation tonight on this very topical issue, and we certainly hope that we can achieve herd immunity soon and get this well behind us. So I really appreciate the discussion tonight. Any other comments by any of the other board members? Okay, great. Well, thank you very much.
Thank you.
Thank you.
Okay, we'll now move on to our medical staff report, and Dr. Killaroo is somewhere there. I don't see your, there you go. There you go. Your video's on now.
Yes, hi. Can you hear me?
Yep. Mm-hmm.
Okay, so we have 583 members on the medical staff, 354 of which are active. There hasn't really been that much change. As I mentioned, we had touched 600 for, I think, 1 month, and then we've been hovering in the 500 since then. Usually around July, when we have the new graduates and the residents coming on, our numbers go up a little bit. We are in the process of doing the elections as the new chief of staff and the department chairs are going to be taking over come July. Dr. Hyder is going to be taking over chief of staff, so he'll be giving these reports starting from July. And we have several department chairs that are also turning over. Dr. Barry is going to be there for anesthesia. Dr. Azizarad is going to be there for the Department of Medicine. Dr. Russell Nord for the Department of Surgery, and Dr. Tan Nguyen for the Department of Family Medicine. The other 3 departments change on the off years. So OBGYN, radiology, and pediatrics will continue. Dr. Pila, Dr. Prasad, and Suddenly blanking, and I'm blanking on radiology, but I'll get back to that. We're also preparing with pretty much the rest of the hospital to get ready for JACO, for the JACO survey, and we are doing our best to assist nursing for the upcoming magnet survey as well. And
thank you very much. Just for everybody's information, what percentage of the medical staff have received vaccination?
So it's over 99%. We have not been able to get all of the documentation because a few of the ambulatory doctors have either received their vaccine through Palo Alto Medical Foundation or one of the other hospitals, and not all of them have been good about sending us the documentation. But verbally, they've said, yes, we've already gotten our vaccine, but we haven't gotten written proof. But yeah, it's over 99%. Pretty much almost everybody that's on the staff has received the vaccination on the medical staff side.
Wow. So let me make sure I heard you correctly. 99%?
Correct.
Wow. Okay. Excellent job. Excellent job.
Thank you.
And I think that's a great endorsement to the public as far as what the right thing to do is.
Yeah, and we have been encouraging all of the medical staff to, when patients come into the clinics and wherever they do, to have that conversation. We have been having regular COVID update meetings, and we have one actually coming up this Friday where we try to disseminate information. We were doing it on a weekly basis, then we went to bi-weekly, and as things started to calm down, we've kind of gone to monthly meetings. But they are pretty well attended. We usually get almost 100 people signing in on those calls on the monthly basis now.
Great. Thank you very much, Dr. Killerow.
Yeah.
Okay, we'll now move on to our Service League report, and welcome Debbie Ferry.
Hi, good evening. I'm going to go right into the report. The volunteers are slowly and safely coming back after the COVID-19 pandemic. We're helping in the COVID vaccine clinic. We have approximately 28 volunteers with 350 hours for March. We're helping in the pharmacy labeling the empty syringes for the vaccine. We're making COVID-19 test kits for pre-op. So they are still being tested, and it's mostly for pre-op or in the ER. And we're helping in the HR with filing. We also have a new gift shop manager, yay, and it's our previous president, Ruth McGuffin. So we're very excited. I kind of begged her to do it. The gift shop was added one more hour to the days, so it's going to be later this month, but we'll be open 4 hours a day, and we're going to one more day, so 4 days a week, which will help with staff and to be able to come into the gift shop and get snacks, unhealthy ones. The days and time will be given later. The Washington Hospital Service League would also like to congratulate our charter member, Laura Pesagano, celebrating her 98th birthday last week. We're so proud to have one of our founders of the Service League still volunteering actively because she does fill out the certificates, and we wish her many more birthdays. And I've actually met her personally, so. And that's the end of my report.
Well, that's great. Well, yeah, very happy birthday to Laura Pisano. She's been a terrific person over the years, and it's great to see the Service League ramping up with the activities within the hospital. You know, the one thing that I really miss, every day I walk into the hospital and I miss seeing all the volunteers at the front desk. And I also miss the volunteers playing the piano. So I know things will really be good when I get to hear those volunteers playing the piano in our front lobby. That'll be music to my ears.
Oh yeah, definitely. We can't wait. We're getting a lot of phone calls of when can we come back? So we're working on it.
Great. Well, thank you very much, Debbie, and good luck to all the volunteers.
Thank you.
Okay, we'll now move on to our next presentation, and Kimberly, if you could introduce our speaker.
Thank you, Dr. Nicholson. This evening, I'd like to introduce Erin Brooks. She's a registered nurse with a Master's of Science in Nursing from Holy Names University in 2020. She began her career at Washington Hospital in 2012 as a bedside nurse in critical care, but has been a critical care nurse since 2007. Erin holds a specialty certification in critical care as well. She has grown professionally in her time at Washington Hospital and is currently the nurse manager for the critical care and intermediate care units. I think Shri is getting her presentation up. All right, Erin, you're on mute. I think you're on mute.
Hi, my name is Erin Brooks. I'm the nurse manager for the intensive. I'm the nurse manager for the intensive care unit and the intermediate care unit. Today, I'm going to speak to you about our initiatives in ICU that we began last year to reduce our hospital-acquired pressure injuries, and this is also known as HAPI. Next slide. So here at Washington Hospital, our priority is to provide safe, high-quality patient care. The objective of patient care services is to reduce all hospital-acquired conditions. Since August of 2020, the ICU has been focusing on the goal of reducing the number of hospital-acquired pressure injuries, or HAPI, that are stage 2 or above. For context purposes, HAPI rates in the ICU have overall decreased. For instance, in the quarter ending September of 2019, the injury rate was reported as 11.76, and it went down to 5.88 in March of 2020. Our ultimate goal in ICU is to reach 0 by June of 2021. Although the National Database of Nursing Quality Indicators, the NDNQI, the benchmark is less than 6, but we're still aiming for 0. So pressure injury rates are considered to be a measure of the quality of nursing care provided. And when hospital pressure injuries are assessed in the hospital, the occurrences are reported to the national database. It's the number of patients that are surveyed in the unit at one point in time, and pressure injuries of level 2 or greater are the only ones reported. This is regardless of where the pressure injuries developed in the hospital. Despite prevention strategies, hospital-acquired pressure injuries continue to occur in critical care, and that's due to a lot of clinical factors that make patients at higher risk. Some of these factors are obesity, immobility, nutritional deficits, and increased illness, especially those, especially of the past year. We've occurred, with COVID-19. We found that a lot had clotting abnormalities, and patients admitted to the ICU were very septic and sick. They often required life-saving medications that bring the blood pressure up, but they have side effects that limit the circulation of blood flow to the skin. So pressure injuries occur most often when there's a decrease in blood flow to the skin. So with assistance from Julie Lentz from Wound Care, Ellen Salindig Noble from Epic, and Cheryl Bonal from Lean, and guidance from Tigist, Brenda, and Stephanie, our leadership team, our team explored how to better reduce pressure injuries and how they could be reduced in the ICU. Next slide. So the key drivers to success of our pressure injury reduction project involved many things. So first, it was staff education, identification of clinical risk factors in our patients that I spoke of before. And a modified screening process was implemented for all patients. We used the Braden scale to drive bundle actions, which I'll talk about. And the Braden scale is really, as I previously mentioned, in assessment is an evidence-based tool that predicts the risk of a patient developing a hospital-acquired pressure injury. And this tool helps us to gauge what needs to be done. So the lower the score, the higher the risk the patient has of acquiring an injury of the skin. So our bundle that we developed is a list of tasks, required tasks that need to be completed every shift. Other key drivers to our improvement involve timely referrals to the wound care team, coordination and communication across other disciplines with physicians, food nutrition services, physical therapy, wound, and pharmacy. So daily huddles were a big part of what we do, which are stand-up meetings in front of an area where we clock in. And we use this to address issues and countermeasures to prevent our efforts, and they were discussed daily. Tracking the process of our audits to ensure that we are on the right track. And finally, we use some visual tools to share with staff and to see where our progress was going and to adjust some interventions that needed to be made. And this was displayed on the frontline board for the team to see. Next slide. So part of our performance improvement, in order to reduce pressure injury in the ICU, we developed a plan to reach our goal by June of 2021. And first, we developed a method to track skin breakdowns by having the ICU staff take skin photos. This is what she's doing in this picture. Take a skin photo of all skin and complete charting on the patient in Epic on all patients, regardless of their skin condition, so getting a baseline when they come in. And then this was our way of documenting a baseline and seeing where the patient was at. Our challenges with this was that there were inconsistencies of when to take photos, and so we created a schedule. So now, in addition to admission screening photos, staff are required to take a photo of all patients every Wednesday, Sunday, and then when the wound care team comes, they do an assessment and they take a photo. And also document in the chart specifically about the wound. We encountered some issues such as awake and alert patients refused photos of their skin to be taken, and that was okay, but that was one of our outliers. And when the patient was very sick, sometimes it made it challenging to stick to the plan because those who were very sick sometimes required immediate attention with medications, respiratory interventions such as breathing tube placements, or other life-saving measures such as CPR, line placements, so they can receive medications immediately. So sometimes those pushed our priorities aside. Next slide, please. So the next action plan was to have daily huddles regarding skin issues and improvement initiatives at the frontline board. Fallouts and skin issues were addressed at the frontline board and educated by the charge nurse or management staff. We were also in partnership with the wound care team to educate staff on skin care. We had encountered some challenges, especially when competing priorities with COVID and the amount of time needed to dedicate to skin problems during this huddle kind of pushed things aside, but we did get back on track. And as you can imagine, during COVID, there were many changing processes, such as from PPE, personal protective equipment, to shield and gown to protect ourselves and our patients, staffing, and then time priorities. But we have been doing a huddle to inform and involve staff in unit initiatives such as this every shift, and this has been since August of 2020, and we continue to do so. In this picture I have here, I've included an example of what our daily huddle looks like with our staff, and our medical director is often involved, and her name is Dr. Carmen Akaloli. Next slide. So next, we started an ICU, pressure injury prevention bundle and skincare guide in November of 2020. The staff were educated on the bundle, and these are a series of tasks that they must do. And we did the education by meeting with unit stakeholders. This is also called unit base in our hospital. And so we brought the information from unit base to our huddles and educated staff, and then also one-on-one in the unit. The list of tasks in the bundle need to be completed daily on their shift to ensure that they were in line with all the prevention strategies that we were proposing and that wanted in place for each patient. The challenges encountered with this were inconsistencies with some workflow and pending products in the bundle that were not yet in place. In the picture here, I have an example of what our bundle looks like when it's written out, when the education was done. Another example is that patients were very sick and unstable and wouldn't tolerate turning and repositioning. So that was one part of our bundle. When we require patients to be turned every 2 hours, sometimes it's not possible when their blood pressure is extremely low and they can't tolerate it. What to do for patient safety, it comes first. So what we put in place was nursing leadership would do rounds. We would do rounds and identify those issues and then put interventions in place to make sure that as soon as the patient could be turned or offloaded with pressure points, that we could get back to preventing any skin breakdown. Next slide. So I also wanted to do a tracking report to show whether bundles were being followed or not. So that was my next initiative. This in the past was very manual and time consuming to go by and document on each patient. So Ellen from Epic created a dashboard for me, for management. And this went live in December, and it contains elements to important to our prevention bundle, such as skin and wound care assessments, photos present, wound nurse consults. We started a bed overlay, or it's like an air mattress that goes over our specialty beds. And if on this report, if it's in use, then it'll show me that it was documented by the nurse and it's being used. The Braden score is shown, patient positioning that was documented, blood pressure elevating medications, if that's a factor, that was documented. So this is a better tool to make adjustments to the plan, and then I'm always making adjustments to this report so that charge nurses also can be involved in the audit process. And this is just an example of what it looks like. Next slide. So Julie from Wound Care provided education on wound formulary and the wound products in January that we enacted into our bundle. And initially the barrier was approval and scheduling and some other priorities in the unit. But the next step is to obtain some approval from the Operations Improvement Committee and some nursing council so that we can begin implementation of these new products that will further assist in our PAPI or pressure injury prevention in our patient population. So the pictures shown here are some examples. The brown overlay that you see, the waffle is on one of the beds, and that's something that we have in place right now. And that is really helping to prevent the pressure injury that we've already seen. So that's really good. Next slide. So this is a run chart that displays our performance outcome related to the reduction of hospital-acquired pressure injuries from December of 2019 to March of 2021. So the blue line displays the ICU-acquired pressure injuries, in which the quarter ending March 2020 was 5.88 and has been reduced to 0 after the implementation of our countermeasures. This is including the routine scheduled skin photos and proper documentation, daily frontline huddles, education and partnership with wound care team, pressure injury prevention bundle tasks, our reporting workbench and dashboard for visual control that I was just speaking of, and the wound formulary of new products. So especially the waffle mattress that was put in place. So the red line is the NTNQI, the National Database of Nursing Quality Indicators. This is their target or benchmark that all hospitals must meet. This is a moving target of 6 or below, and that's why you see such a variation in the line. So we've sustained our hospital-acquired pressure injuries of stage 2 and above from 0 from above to 0 from June 2020 until now, March, April 2021. Next slide. So our next steps in our plan is in ICU is to continue active daily management of our bundle and what we've put forth, staff engagement, and it's kind of always bringing it up to the surface again, right? Bringing it back and talking about it, and communication is like really the key. Visual management, our tracking and audits, and using what we have in place. Interdisciplinary collaboration with food nutrition services, rehab, the wound care team, physicians, and pharmacy. And then revisiting our PDCA cycle, our plan, do, check, act cycle to enforce and focus our goals and adjust improvements as necessary. So that's what we're doing in ICU, and thank you very much.
Thank you,
Any
Erin.
questions?
Do we have some questions? Okay, no questions, but very impressive results. And, you know, I think this really emphasizes the efficacy of using lean principles to address the processes by which we try to fix very complicated and difficult and challenging issues within the care of patients. And clearly what you've been working on is not an easy thing to fix.
Yeah.
And this is just so gratifying to see these beautiful results from this. And so the more we can use these kind of principles to pick a problem and attack it, the better our healthcare will be, and the better outcomes we'll have with overall patient care. So really, thank you very much, Erin, for the great work that you've done and will continue to do. And I just wonder what the next projects are going to be.
Thank you.
Great. Thank you. So now we'll move on to our quality presentation, which is Dr. Martin and C. Diff. Is Dr. Martin with us?
I believe she is, and I'll just give an overview. I think I know all of us, many people do know Dr. Martin. She is going to give the annual antimicrobial stewardship update, and she is our antimicrobial physician leader, and she has been a member of Washington Hospital's medical staff since 1984. She has served in many leadership roles at Washington. She has been a physician champion for a 5 Million Lives campaign. She has been the chair of the Department of Medicine and chair of Clinical Evaluation Committee. Dr. Martin attended medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at the UC Davis School of Medicine, and she serves on the board of directors of Life Elder Care and is a member of Washington Township Medical Foundation. So I believe she's there.
I'm on. Can you hear me now?
Yes.
Okay,
Thank
good.
you.
Okay. So the antimicrobial stewardship program looks at multiple areas throughout the hospital, and we aim to be multidisciplinary. So we incorporate both nursing, pharmacy, IT, lab, and trying to create a whole picture of improving our antibiotic use for all of our patients. Most of this is focused on the inpatient side, and we eventually would like to expand to working with our outpatient population and the ambulatory care physicians. So that's kind of a long range project. So the mission statement we have, because Joint Commission recommends that we have this just so that we can show people what we're focusing on and what our biggest projects are. So we want to make sure that we are using antimicrobial agencies appropriately. And we do this through education, nursing education, physician education, pharmacy education, implementation of accepted protocols. Many of the protocols come from greater agencies like College of Physicians, the Society for Hospital Infections, IDSA, which is Infectious Disease Society. And we also try to aim for interactive discussions. So we have fairly frequent meetings, sometimes broad spectrum, but sometimes targeted with both medical and the healthcare staff. Again, pharmacy, nursing, IT lab, to make sure that we are providing the best possible care and outcomes for our patients while minimizing resistance. Next slide. So the question is, what exactly is resistance? And that is something that occurs when a microorganism can stop an antimicrobial, be it antifungal, antiviral, antibacterial, from working against it. So when these standard treatments that we use, for example, penicillin, become ineffective, infections persist and they can spread throughout the organization. There are new resistance mechanisms, just like Dr. Kataya was talking about, the variants for the viruses. There are new resistance mechanisms for both penicillin and some of our more efficacious antibiotics, and they're emerging not just in US, but globally. Resistance then costs a lot in terms of patient care. We want to provide the best care so that they are here for the appropriate amount of time for the right diagnosis, but not prolong it any more than need be. But resistance means that sometimes patients are going to take a longer time to get better. They need lengthier hospital stays and sometimes needing more intensive care unit type care. Next slide. So we do have, fortunately, been very honored to have this, as we have a lot of leadership commitment, both from the higher level of the executive staff all the way down to the nursing staff and pharmacy that back us up, including EVS. We're really blessed to have as much backing as we do on all levels. So Washington Hospital implemented a dedicated program in 2010. It was based on the Centers for Medicare and Medicaid Services that this be a requirement for antimicrobial stewardship. And it was placed under infection prevention as of June in 2016. Our committee supports effort to improve and monitor antibiotic use. We have dedicated staff, such as Lena in the pharmacy, and we also get a lot of resources from Mary and the infection prevention staff. They have a small but dedicated budget. We're ensuring staff from the relevant departments are given enough time to contribute to stewardship activities. So we have meetings where the nursing staff has allowed them to come to these, pharmacy, IT, lab, to participate in discussion so we can figure out how we want to address issues that come up. How can we best adopt standards and guidelines for our hospital? So we support training and education. We also ensure participation from the other groups that can support the stewardship activities, and that involves many of the physicians as well. Next slide. So the program elements include in a disciplinary approach. Like I've talked about, we use many different groups to help us. We are primarily looking at drug utilization and targeting the high-risk antibiotics. So these are antibiotics that are very active against very resistant bacteria and antifungals, and we want to make sure that they are used appropriately. So we're working on usage guidelines and education. So we work through this to try to figure out best things. And just like Dr. Kataya presented with the virus, things change. So what we worked on last year needs to be updated every year to the resistance patterns that we have within our own hospital. Education goes through the nursing staff, through their teams, also going to each of the departments of medicine, family practice, surgery, presenting at the medical staff meetings as well. We have a pharmacist consultant who's very important to this program. Lena Wong has dedicated hours and hours and constant hours to helping us get things put together. Just this presentation alone took many hours to get together. one of the areas that we wanted to look at is the use of certain antibiotics such as penicillin, which is a very common drug. And many people say, oh, I'm allergic to this. And when we try to drill down to see what exactly is it, oh, they say I have nausea, or my mother told me I was allergic, or any number of things that just really don't make good medical sense. So we've gotten a sensitivity program where we're trying to make sure that we can test patients while they're in hospital or even in the ED to see if we can still use penicillin safely. So we have that availability. We can do skin sensitivity. We can do desensitization where penicillin might be the best and only drug to be used. We've also been very fortunate to have electronic medical record that is just indispensable in trying to do the infection prevention work and also the antimicrobial stewardship work. We have many infection-based order panels, and we're updating those on a regular basis. We submit data to NSHN, which basically is part of CDC, where we use a lot of our baselining ourselves or monitoring ourselves against other hospitals and areas throughout the nation to make sure that we are staying up with current guidelines and that we are making best options for care for our patient. So again, a best practice advisory we send out periodically through, we had been doing newsletters, but doing other activities. Next slide. So this is how we look at antimicrobial use. So you may have been familiar with what we look at as the SIR, which is a standard infection ratio. This is standardized antimicrobial administration ratio. And just like you'd seen in some of the other slides, like Erin was talking about, 1 is the baseline. So we're trying to shoot for less than 1, which means that we're better than the average, and avoid the over 1, which is worse than average. So if you look, the worst that we were back in April probably, and this was at the onset of the COVID, where things just got way out of control. So we have been working very diligently, and you can see currently our last 2 quarters, we are below 1 for our antimicrobial use. Next slide. So this is a little bit busy slide, and I'll walk you through it. So it's a pie chart looking at antibiotics. And right now we're looking at the gram-positive antibiotics, which would be most of your staph and strep. And again, staph is one of the bacteria which has more resistance within most organizations, ours included. And then we also want to look at, again, at the broad spectrum antibiotics. So these are our go-to drugs that we use when we know or suspect the patient may have resistance. And want to make sure that each of these are used appropriately. So when you look at our little charts, the pink line is the IMC, intermediate care unit, which is where Erin is working, and we want to make sure antibiotics are used there appropriately for her wound infections, patients that come in with pneumonia and other infections. That number looks a little bit skewed. And again, 1 is the baseline where we want to be less than 1, and above 1 is not up to par. So this unit is very small. It's only about 12 beds, and they're mostly in transition. They're going from the ICU to the floor where they need a little bit more step down care. So we want to go forward this year to look at those areas in particular to see where we can improve. The sort of more lime green line is ICU, and you can see they're doing very well. The dark green line is the ICU. So currently what we're doing with our stewardship program is to look at methicillin resistant staph aureus, which is basically the penicillin staph aureus, and we use PCR, which is looking at the particular RNA, the DNA of the virus, DNA of the bacteria to guide us whether or not this is present. So we can do a swab of the nose looking at a patient who's coming in with pneumonia, maybe a very debilitated patient coming from the dialysis unit, maybe a patient is coming from a skilled nursing facility. So if that MRSA PCR is negative, it's strongly indicative that that patient would not need vancomycin. So we can use that as a guideline so that we can make sure that because obviously the cultures take many days to come back. If we know going up front that penicillin resistance is much less suspected, we can tailor our antibiotics to avoid the use of vancomycin which again is used for resistant bacteria. And if you're using it for the common bacteria, we're going to eventually develop more and more resistance. The other thing we're encouraging physicians not to use is double anaerobic combinations. So it's not if some is good, more is better type combination. So the piperacillin tazobactam is a standalone very good antibiotic and does cover anaerobes, does not need metronidazole added. Metronidazole is fragile. Meropenem is again a highly used drug for resistant organisms and does not need metronidazole in addition to that. The other set of the slide is the, 1 second, I've lost my slides. Sorry. Okay, sorry. I need to move my cue down to the bottom. Okay, so the other half of the slide is the broad spectrum antibiotic usage, and you can see the pie chart looking at all the different ones that we're using. The dark green on the bottom, it says cephalosporins, which is probably our biggest use. That also includes the pre-op antibiotics used for surgery. So we look at that. Going up, we're looking at the fluoroquinolones, which is our anti-fungal. And then the next one up is the glycopeptides, which is the vancomycin. And then you're looking at the penicillins, tetracycline, and then the beta-lactamates, which again is the piptazo group. And the carbapenems is our top of the line stuff, which is the meropenem, which is used for most resistant bacteria. So again, you can see the pink line, which is the IMC, does not do as well. But again, we want to study that group in better detail. It's a very small group. It's a group in transition. The other two groups between the ICU and the med-surg are doing very well. Next slide. Okay, so this is our antifungal. And again, you can see the difference between the different units, the IMC not doing as well, the med-surg and ICU doing quite a bit better. If you look at the pie chart, the azoles is the diflucan, which we're using quite a bit of. The echinocandins are the ones we want to keep in reserve because that's what we use for our resistant ones. And we did have sort of when we were dealing with more COVID patients, a lot of them were intubated and we were seeing more of the the fungal infections in those patients. One, because they were so critically ill. Two, because they were intubated for much longer periods than we have seen in almost any other unit outside of a burn unit. Current stewardship is recommending that these antibiotics be restricted to the ID physicians and the intensivists. We have developed a hard stop indication for most of these antibiotics, such that when a physician puts in the order, it asks for the diagnosis that they're considering, and it also asks them to please contact one of the ID docs or the intensivist to prescribe these. And the pharmacy looks at that and will check before it releases the drug. So again, the IDs have done an outstanding job of making themselves available 24/7, 365 to the primary care physicians, the down physicians, the surgeons. If they feel that this particular antibiotic is really needed, that we make ourselves available to discuss the case and then give the okay, or perhaps suggest something that might be more appropriate. We also have treatment bundles for invasive candidiasis and invasive aspergillosis, which we saw more of when we were looking at the COVID patients in the unit over the last year. Next slide. So here's the C. diff ratio. Again, 1 is the goal. And you can see we sort of bumped up a little bit the first part of the year. I think a lot of that had to do with the super high census that we're dealing with when we had the influx of the COVID patients. And in the last 2 quarters, we have gotten to our goal of being below the average. So we're at 0.9. So that's what we're looking for right now. So far, so good. We've been working with the infection prevention team to try to streamline our C. diff testing so that it's a little more clear in terms of the focus, and also working with nursing who have done an outstanding job of trying to make sure that we're doing appropriate collections for patients and then getting that to the lab. The lab is also working very diligently to make sure that the specimens are appropriately and processed. Next slide. So these are some guidelines and protocols. I know it's getting late, so I'll just kind of let you know. This is skin and soft tissue infections, urinary tract infections, pneumonia, catheter-related bloodstream treatment guidelines. This is mostly for physicians and nurses. It's on our intranet. These also list another of the other guidelines that are available. The surgical prophylaxis guidelines were just updated in the last couple of months because of their societies giving us new updated guidelines, and that was presented at surgery department meeting. Next slide. Touching base a little bit on the COVID treatments, this is a list of the ones that we have available. The remdesivir, and I'll get to that a little bit later here. The monoclonal antibodies are the last three groups. The tocilizumab is one that's used for rheumatoid arthritis, and so is the baricitinib. All of these are basically emergency use authorization, so they're not approved for COVID, but they are very effective for COVID. Next slide. So this is a very busy slide, but it's meant for reference for physicians, and this is updated almost every couple of weeks based on what's being new in terms of treatment for our patients. So this is the way physicians can look in a very quick format to see what's available for their patient and what's been looked at, studied, and considered. So we look at, if you're going from your left, the asymptomatic or pre-symptomatic, basically stay home. The mild illness are the ones where we want to consider the monoclonal antibodies. The moderate ones are ones that are usually admitted, and generally monoclonal antibodies not indicated. The next ones are looking at score 5, 6, and 7. So 5 is where you have a COVID patient who is needing oxygen, but not on high flow, which is score 6, and not on 7, which is the intubated patients. Next slide. Sorry, I need to keep my click. So this is just a brief update on the monoclonal antibody formulary review. We have 2 that are available, and this has been educated for the physicians of how to access this. We have an order set and a particular appropriate patient access that we are having it basically about once a week. And that, again, like everything else related to COVID, is in process of being changed. Next slide. So people say, well, what are monoclonal antibodies? So they basically help you fight off the viral infection. So without the antibodies, the virus can attack the cell. With the antibodies, basically, if you get it from convalescent plasma or if you're getting it from these monoclonal antibody infusions, basically block the virus from entering the cell. So currently we have a COVID therapy center that is available on Tuesdays only. And again, we're looking at trying to expand that through the ER to make it a little more available for our patients. The current monoclonal antibodies are available through Alameda County Public Health Department. Next slide. So the criteria for use are very specific for this. It has to be a mild to moderate patient. They need to have basically underlying illnesses, and they need to be sick enough to need something, but not with a very low oxygen score. So if their oxygen score percent saturation is below 94, we don't consider them a candidate. Because again, using this, even though it looks really good in a patient who's actually more sick, is not appropriate. This just lists for the physicians that when they want to see, is my patient a candidate for it or not? This is the system that they would look for. And this is on, again, on our intranet and also on the order set that a physician would use in trying to order this. We do have it available to a 12 to 17-year-old age group. We have not used that yet, but it is available for that age group with COVID infection. Next slide. So it's not authorized for patients who are hospitalized for COVID-19 or require higher oxygen or on chronic oxygen therapy, as again, that's been found not to be beneficial and can actually make those patients worse. Next slide. So we asked the physicians to educate their patients before starting this because it is emergency authorization only. So patients and our family or the guardian needs to understand that. We have a fact sheet that the patients are given when they check into the COVID therapy group. And we ask the physicians to make sure that they document a follow-up call a few days after discharge to see how the patients are doing. And the patients are also educated that they still need to self-isolate, still need to use infection control measures such as mask, isolation, social distancing, and avoiding sharing personal items. So just exactly like they would before they were treated, they still need to do it after they were treated. Next slide. So this is our remdesivir usage. So remdesivir is currently a major drug that's available for treatment of COVID. And you can see we started using it back in May when it became available. We had a slight blip up of use in July and August, and then we had this enormous surge in December and January. So the little red line shows you the cases that we were studying to see how we were using remdesivir based against national recommendation and what our outcomes were. So this represented almost 430 patients. Total, we used about 225 that were in that higher population group from December to January, February. We went through 80 charts, which took almost probably 200 hours just going through that alone. Gender, we had more male than female, but female were a little bit older. In terms of ethnicity, our largest group is Asian, which included Filipino, Indian, Chinese, and the South Pacific Rim nationalities. We had very few Black, more Hispanic, white, Caucasian 17, a few Native Hawaiian or Pacific Islander, which had been known to not do well, and then 2 that we could not identify. Next slide. So this breaks up the use according to the score. If you remember the back slide that we used, the 4 is basically a patient not requiring oxygen. 5 is on low flow. 6 is on what they call high flow or non-invasive, and 7 means intubation. So the number of patients we had, most of them fell into that category 5. And that is actually the category where those patients actually did the very best. So we had fewer that were expired, a few that went home with hospice, which we basically considered also relatively as expired. So that group did the absolute best. When we looked at the ones that were admitted to the CCU on day 10, on day 1, 10 of those were 10 patients with the average length of stay of 8 and average length of hospital stay at 12.6. Those that started out on a different unit and then transferred to CCU later were 9. Again, a longer stay because you can see they probably are not doing as well, both in CCU and average length of stay. Those were on the med surge unit, which was our mostly the 5 West and a little bit of 3 West when we were at the high capacity, did a little better in terms of length of stay. So overall, we looked at 80 with an average length of stay in the CCU of 10 and an average length of stay of 10. There are very few benchmarks out there. So we're using BD, which is the old Benton Dixon, and they make a number of pieces of equipment that we use throughout our hospital, as well as does many other hospitals in the United States. You can kind of see that their data goes up to 8 of 20, which was not the area that we were truly looking at when we were looking at our December surge data. So, but this is the only ones that are out there basically looking at length of stay. So even though we had sicker patients and we were a little bit longer in terms of length of stay, I think it reflects that our team is doing moderately well with how we're doing it. Both the pharmacy, the nursing, and our intensive care unit staff, and the heroic staff on 5 West. I can't imagine how they got through their days because they did a tremendous job with patients, informing families, doing iPad connections with them, reassuring patients that were in rooms by themselves, using the baby monitors to connect with them. They did a heroic job. Next slide. So this is a little bit of busyness, but it's basically our intranet, which shows physicians how to access information. So they can look at the vaccine overview. And just like Dr. Kataya was talking about, we're updating this almost daily. And this is the CDC fact sheets and other information that's available to the physicians and also hospital staff on our intranet. Next slide, which I think is the question and answer slide. Yes, so I'll take any questions.
Any questions for Dr. Martin?
Oh, no questions. I'm just really impressed with the work these people have done. My word, what an incredible bunch of data to look at, and yet showing a lot of work and a lot of success. Very reassuring about how our patients are doing.
So, I mean, a lot of our learning was sort of, day by day and things changing remarkably between when we first started working with these patients in early March to even now. So, I mean, it's an education in progress, but I think we've done pretty well with maintaining best outcomes, best care for our patients.
Well, thank you so much, Dr. Martin. Really
Okay.
appreciate the update.
My pleasure.
Thank you.
Everybody be safe.
We'll do our best. Okay, we'll move on to our finance report with Chris Henry.
Thank you, Sheree. Thank you, Dr. Nicholson. Tonight, we'll be looking at the operational and financial results for Washington Hospital for February. And we'll move right into our operating statistics. Average daily census for the month came in at 154.1, 7.7 higher than we expected in the budget. Admissions were 154 below budget at 683, but our patient days were 217 higher than budget at 4,315. Same pattern we've been seeing really since the beginning of COVID. Our outpatient observation equivalent days for the month came in at 189 against the budget of 149. And as you would expect, our average length of stay based on discharges came in at 6.83 against the budget of 4.9. That number in February carrying some pretty telling numbers. In that 6.83, we had 107, and I think Kimberly mentioned this last month, we had 107 COVID discharges. That 107 discharges had an average length of stay of 10.6. We also had 3 non-COVID outliers discharged in the month with a length of stay of 85, 111, and 247 days. So if we just eliminate those 3 outliers, the average length of stay comes down to 5.6. So again, you can see the impacts of COVID on the length of stay. Moving into, Shree, I don't know, there we go. This thing is delayed. I don't know if the batteries, Shree, will you drive? Yeah. Okay, moving into our operating indicators. Case mix index for the month was still relatively high, but lower than what we'd seen in the last several months at 1.547. We expected 1.490 for February. Deliveries were 31 below budget at 92. Surgical cases for the month were 16 below budget at 316. We'll get into the details of that in just a second. Cath lab procedures came in 1 above the budget at 332. Outpatient visits for the month were 253 below budget at 6,556. And our emergency room visits for the month continued lower than expected, 762 visits below budget at 3,077. And of course, we closed the RSTU several months ago. Next slide, please, Sri. Getting into the OR and cath lab details, as I said, surgical cases were 16 below budget, largely driven by our joint replacement procedures. If you recall, in February, we were really heavily impacted by COVID and really cut down on some of the elective cases, and that really impacted joints. Neurosurgical cases for the month and cardiac cases came in higher than budget. And our general surgical cases offset those, coming in 9 below budget at 147. Cath lab procedures, again, were 1 above the budget. Peripheral vascular procedures really had a larger variance than most, 8 below budget at 141. Cardiac procedures came in pretty close to budget at 110. Non-vascular interventional radiology procedures were 10 above budget, and neurointerventional radiology procedures came in right on budget at 5. Moving into productivity, productive FTEs for the month improved, but still higher than budget, 65 above budget at 1,346.6. We had 173.7 non-productive FTEs recorded for February, leaving us total FTEs 64.2 higher than budget at 1,520.3. Our full-time equivalents per adjusted occupied bed, this is our productivity measure, coming in higher than budget by 0.18 at 6.59. Moving into the financials, and as always, we'll look at our Governmental Accounting Standards Board presentation first. This is the presentation required for our audited financials. Gross patient revenue for the month came a little over $9.8 million, higher than budget at $167,409,000. Our deductions from revenue came in a bit higher than expected at 77.87%. We had budgeted 77.79%. Shri, if you could advance the slides, please. We'll look at the detail of that. Our contractual allowances, which include all of our insured patients, came in at 75.99%, a little bit higher than the budget at 75.74. Government payers in the month came in slightly higher than budget at 71.7%. We had expected 71.2% for government. PPO came in higher than budget at 25.2% of gross revenue. We'd expected 23.9%. And HMO came in 0.6 lower than budget at 2%. Private pay for the month came in at 1.88% of gross revenue versus 2.5% as the write-off percentage. In the actual mix of gross revenue, private, we had expected 2% for private pay, and we recorded 1.1%. So we got a little bit of help from private pay in our provision for bad debt and charity. Okay, Shri, we can move on. Thank you. So we ended up with net operating revenue pretty close to budget, about $134,000 higher than budget at $37,329,000. Operating expenses came in $584,000 higher than budget at $38,736,000. Had some offsets going on in there. Salaries and wages came in at $1.36 million higher than budget with our higher FTEs. Our benefits were below budget by $681,000. We had some offsetting going on in there. Blue Shield claims for the month were $284,000 lower than budget. We had our lower pension expense as a result of our financial results in the pension plan. That came in $648,000 below budget. But our employer taxes, because of our higher wages, were up $152,000. And dental claims were $60,000 higher than budget in the month. I think people had been working and not taking care of their dental needs, and so I think we had a high month there. Supplies for the month came in $97,000 above budget. Big movers there were prosthesis, coming in lower than budget by $184,000. That was offset by our lab supplies that were above budget by $125,000, and that's largely COVID reagents. And our PPE continued to be higher than budgeted by $186,000. Pro fees for the month came in below budget by $193,000, driven by consulting, medical fees, and legal expenses. And then we had some smaller variances in utilities and marketing expenses, and we had some shared saving costs with our physician partners in our shared savings program. So we ended up February with an operating bottom line about $450,000 worse than budget at $1,407,000. Non-operating income for the month from a GASB perspective came in almost $1.2 million better than budget at $807,000. We did have an unrealized loss on our investments in the month of about $930,000, and we received a donation from the foundation of almost $1.7 million, so it was nice to receive that. We actually recorded an accrual for that in February, and they actually passed the money in March, and I think Kimberly's going to talk about that a little bit. So we end the month with a total bottom line for Washington Hospital in February, $747,000 better than budget, with a loss of $600,000. So some improvement there, but still a lot of work to do. Moving into our Financial Accounting Standards Board presentation, and again, this is a representation of how the financial markets might adjust our GASB presentation when they look at us. First thing we do is we reclassify our revenue bond interest expense out of non-operating income and up into operating expenses. And we end up with operating income from a FASB perspective that is $207,000 better than expected at better at a loss of $1,938,000. We then go down into non-operating income, and we remove that unrealized loss on our investments of $130,000. We also remove our revenue bond interest expense and the related tax income for that to end up with non-operating income $1,437,000 better than budget at $1,964,000. And actually net income from a FASB perspective of $26,000 against a budget of a loss of $1,618,000. Quick look at earnings before interest, taxes, depreciation, and amortization. And again, this kind of gives us an idea of how much income the operating and non-operating activities of the hospital are providing to cover our interest expense and other program and capital needs. We look at our operating expenses, excluding depreciation, to come up with EBITDA of a little over $2.5 million, about $611,000 less than we had expected in the month. And then we move down to our non-operating income and expense, and we carve out our interest expense to come up with non-operating income of almost $2.5 million. So in total, operating and non-operating activities provided just a tad less than $5 million to cover our interest expenses and capital and other programmatic needs. So are there any questions on February's results?
No, thank you, Chris. Really appreciate that. It just, I can't say how much we appreciate the foundation donation. I wish we could have that every month.
Yeah, and they work really hard to do that for us, and I agree with you. We really do appreciate it.
We're so grateful for that beautiful contribution. So let's move on to our operations report for March. Kimberly.
All right, thank you. Just a couple of comments about March of 2021. This was the month that we started to see our COVID inpatient census significantly drop, and so you'll see that. Also, in the comparisons to March of 2020, I think we all do remember that it was March 17th of 2020 when the 8 Bay Area counties, everyone had to shelter in place. So that's just when we look at the comparisons, you will knowing that that was what was happening at that time. So looking at March of 2021, gross revenue of $183.7 million for March was above budget by $1.7 million, or 1%, and above March of 2020 by $31.5 million, or 20.7%. Inpatient gross revenue of $114.7 million was below budget by $3.8 million, or 3.2%, but $8.5 million, or 8% above March of 2020. And outpatient gross revenue of $69 million was above budget by $5.5 million, 8.7%, and $23 million, or 50.1% above March of 2020. So in March, just to give perspective, we had 36 COVID-19 discharges, representing about 5% of our total discharges. In the prior 3 months, COVID-19 discharges averaged 149 and represented about 20% of total discharges per month. So you can see it was a significantly reduced number of inpatient COVID-positive patients. Also, due to the shift in joints, inpatient gross revenue is $6.3 million lower, and outpatient gross revenue is $11.3 million higher than the prior year period. So those are two pieces of information that's important to know. So moving on to key statistics, our average length of stay of 5.7. As you can see, it came down from the February of 6.83, but was still above the budget of 5.07 by 0.63 or 12.4%, still resulting that we had a higher acuity of our admitted patients. Outpatient observation days were 59 or 31.7% above budget at 245 days. Outpatient observation days were 89 or 57.1% above March of 2020. And an average daily census of 138.9 was below the budget of 151.4 by 12.5 or 8.3%. And again, you can see it's about, average daily census was about the same as March 2020. In general, our COVID-19 patients have had a higher acuity and average length of stay at 9.5 days. The average length of stay for the 36 COVID-19 discharges in the month was 16.1 days, and 11 of them had stayed longer than 20 days. So you could see in terms of driving up our average length of stay. I do want to say we still, at the end of the month in March, we still had in-house, we had 4 patients with very long lengths of stay. Average one was 60, one was 63, one was 154, and one was 196. I will say at the very beginning of April, we did do a discharge to 2 of the high length of stay patients. So we will probably again see April with a high length of stay, given those 2 patients with basically close to 200 days at that time that were discharged. So moving on to the admissions. Admissions were below budget by 132 or 14.3%. Admissions for the month were 2 or 0.3% below March of 2020. We've continued to see the shift in joint procedures from inpatient to outpatient. Looking at our patient day trends, although admissions were 14.3% below budget, our patient days of 4,305 were only below budget by 8.3% or 388, again due to the longer length of stay of many of our patients. Looking at our surgical trend, total surgeries in March of 392 were below the budget by 3 or 0.8%. Surgeries were 114 or 41% above March of 2020, but thought that would be also important to look at the prior 8-month average. So the pre-COVID average per month was 382. So 392, we're seeing our surgical volume pick up in terms of compared to pre-COVID times. Inpatient surgeries were 46 or 22.3% below budget at 160, and our outpatient surgeries were 43 or 22.8% above budget at 232. And again, the shift in joints is really driving that more towards the over budget in the outpatient surgeries. Looking at the breakdown of the surgical activity, neurosurgical procedures were below budget by 3 or 14.3%, that were the same as March of 2020. Looking at the prior 8-month average was 23 versus what we did this March of 2021, which was 18. Our cardiac surgical procedures were below budget by 2 or 12.5% at 14. And again, the prior month average pre-COVID was 11. So we saw some increase in that. Our joint replacement surgeries were above budget by 1 or 0.6% at 166. And the prior 8 months pre-COVID average was 153. So that's, again, we've seen our joint surgeries pick back up. And general surgical procedures were above budget by 1 or 0.5% at 194. And the prior month, 8-month average was 196. Looking at our cath lab, as you can see, we had a very busy month for cath lab procedures. So cath lab procedures for March of 528 were 169 or 47.1% above the budget, and 315 or 147.9% above March of 2020. And the prior 8-month average was 426. So again, some significant increases in the cath lab procedures. If you remember, we now have 3. Dr. Bruce Lin brought in Dr. Hansra, who joined him, and also Dr. Lauren Chen is another physician that has joined Dr. Bruce Lin. Inpatient cath lab procedures were above budget by 103 or 49.3% at 312, and 175 or 127.7% above March of 2020. Outpatient cath lab procedures were above budget by 66 at 44% at 216, and above the prior year by 140 or 184.2%. Moving on to our cath lab activity, you can see it broken down. Our peripheral vascular procedures were above budget by 131 or 84.5%. And comparing that to the prior 8-month average pre-COVID, which was 197. So definitely saw a significant increase in the peripheral vascular procedures. Our non-vascular interventional radiology procedures were above budget by 23 or 29.9% at 100. And again, the prior 8-month average was 88. So again, that area has increased. Cardiac procedures were above budget by 12, 9.8% at 135, which was just on the prior 8-month average was also 135. Neurointerventional radiology procedures were above budget by 3 or 75% at 7, and our prior 8-month average was 6. That was a busy month in the cath lab. Our deliveries, for March was 102, which were below budget by 27 or 20.9%. We did start to see a slow increase. I know we've talked to many of the OBs, and they do have a number of mothers that they have deliveries that are coming up in the future. So hopefully we'll continue to see this number increase. Looking at our non-emergency outpatient visits of 7,990, we're above the budget by 708 or 9.7%, and we're above March of 2020 by 2,668 or 50.1%. It's broken down in terms of looking at our cardiac rehab visits. They still have been below budget by 203 or 26.3%, and have been challenged in terms of really being able to bring back these rehab classes are usually done in groups, and so we've not been able to bring back the groups together. So we've been doing it sort of on a smaller group basis. The x-ray visits were above budget by 113 or 6.4%. Our lab visits were above budget by 465 or 17.4%. And our EKG visits were above budget by 129 or 131.6%. Moving on to our emergency room visits trends, you can see that emergency room visits of 3,418 were below budget by 984 or 22.4%, and below the same period of last year by 243, 6.6% visits. And just looking again at that prior 8-month period, on average, the monthly number of visits was 4,454. So this continues to be one of those departments that we have not seen sort of move back towards the pre-COVID time. Moving on to gross revenue recap, looking at our emergency visits, we're below budget by 984, or 22.4%, driving emergency room revenue down by $2.5 million or 21.1%. Our patient days were below budget by 388 or 8.3%, but patient acuity was high, resulting in room and board revenue down by $1.2 million or just 3.3%. Deliveries were below budget by 27, 20.9%, driving birthing center revenue down by $870,000 or 25.9%. Our total surgeries were slightly higher than budget, and surgical services revenue was higher with budget by $73,000 or 0.2%. Outpatient visits drove ancillary services revenue above budget by $1.8 million or 2.2%. And cath lab procedures were above budget by 47.1%, driving cath lab procedure revenue up by $4.4 million or 34.1%. So again, cath lab did well in terms of revenue too. Unfortunately, we still had another challenging month with our payer mix. As you can see, government-sponsored patient revenue made up 75.1% of total gross revenue. This is higher than budget by 3.5% and higher than prior year by 3.8%. HMO was 2.8% of gross revenue, which is above budget of 2.6% and the same as prior year. PPO was 21.1% of gross revenue, which is below the budget of 23.8% and lower than prior year 24.3% of gross revenue. And private pay was 1% of gross revenue, which is below the budget of 2%. I know that finance has been looking at sort of where we are with a payer mix and net revenue, and preliminarily it looks like our net revenue is down by about $1 million compared to budget at this point, but it's still early in terms of looking at it. Moving on to preliminary productivity indicators, our productive FTEs were below budget by 6.5 or 0.5% at 1,306.3. Our non-productive FTEs were above budget by 1.9 or 1.4% at 133.6. So our total FTEs of 1,439.9 were below budget by 4.6 or 0.3%. Looking at our productivity measurements, productive FTEs per adjusted occupied bed of 5.87 were higher than the budget of 5.65 by 3.9%, and total FTEs per adjusted occupied bed of 6.47 were higher than the budget of 6.21 or 4.2%. So we still need to continue to look at our flexing. We've also have brought down our unbudgeted FTEs overall from where they were in past months. Moving on to our operational outpatient statistics, Whitman clinics were below budget in March by 810 or 4.5% at 17,314. This was 4,575 or 35.9% above the March 2020 visits. We still have some specialty areas that have been running below budget in terms of cardiology and urology that are making up some of the difference in terms of the volume being down. Looking at our DevCo visits, 2,996 were below budget by 536 or 15.2% for the month of March. As you can see, this is really driven by two areas. The first is Washington Urgent Care. As I've talked about, we have reduced the hours from February, reduced the hours to only in the morning hours, and so this has also reduced the number of visits. Also, Ohlone College Student Health Center remains closed at this time. But you can see our Washington Outpatient Surgery Center is above budget by 19 visits. Also, our Radiation Oncology Center is above budget by 110 treatments. As you know, we implemented the new linear accelerator at the end of the year last year. And Washington Outpatient Rehab Center was above budget by 124 visits. Moving on to our key financial statistics, our days cash on hand for March ended at 159 days, an increase of 3 days from last month. This is due to we received our hospital quality assurance fee of $8.8 million, which was about 8 days. This is a Medi-Cal supplemental fund that we received, and we had done an intergovernmental transfer back in December for $2.7 million. Also, this is, as Chris mentioned, this is where in March is when we actually received the donation from our charitable foundation of about $1.7 million. About 787,000 of it was earmarked for the critical care campaign from pledges that continue to come in. About 450,000 for COVID-19. We also had 182,000 around surgical services, 113 for oncology services. So again, we very much appreciate all the support from the charitable foundation and all the donations that have come in through our community. Also, we did have quarter ending March 31st, we did have a pension and funding of $6.6 million. So that we did do that. In April, we will have funding of the 403B match of $2.2 million. You can see our days of gross revenue and accounts receivable were 64. We still have a number of high volume, high dollar, and high acuity patients compared to last year, which was at 54. And there were $334,340 in charity care applications pending for approval in March. Are there any questions?
Yeah. How will we account for the $8 million Medi-Cal payment that you mentioned?
Yeah, that goes in as a reduction to our contractuals. It's something that we accrue ahead of time, so it's already baked into these numbers.
All right.
Always a delay.
Okay, never mind. Never mind.
I know.
Yeah. Sorry about that.
Yeah.
Yep.
Yeah.
You're really looking for some good news, aren't you, Mike? Yeah,
I asked the same question.
clearly the challenges remain. It's good to see the interventional radiologists working hard. So that's at least a bright side there. I'm glad they're able to help so many people. Okay, any other questions for Kimberly on March operations? If not, Kimberly, do you have announcements?
Yes, I have a couple of things. I want to start with the Employee of the Month for April of 2021. This is Raymond Espinosa. He is a RN in perioperative services. Raymond has been with Washington Hospital since March of 2001. He started on the medical surgical floor before finding his home in the operating room in January of 2003. It was about that time when coworker introduced Ray to a nurse from 6 West, Maricel. They began dating, and now after 17 years of marriage, they have 3 beautiful daughters. Working in perioperative services, often as the charge nurse, requires a specific set of skills where a collaborative environment is very important, and Raymond is key to that dynamic. Both before and during surgery, Raymond's primary concern is the safety of the patient. He focuses on both the technical things, like making sure everyone has the supplies, instruments, and equipment they need for the upcoming procedure, to more individualized patient needs, like proper body positioning for the specific type of surgery to prevent intraoperative injury. Prior to the first surgical incision, Ray always participates in the surgical timeout, a key safety measure to prevent injury to patients. The teamwork of the department is what Ray really likes the best. They may be a group of people with different backgrounds and different areas of expertise, but team members in the operating room come together with one goal, the best outcome for the patient. Many of his peers describe Ray as a team player and a passionate nurse with a great sense of humor, who has the respect of his coworkers, managers, and surgeons. Ray is respected, admired, and well-deserving to be our April Employee of the Month. Congratulations, Raymond. All right, and then I'd just like to talk about a few of the events that we held, I should say educational Zoom events that we held in March. We had some very successful ones. On Tuesday, March 16th, Dr. Stephen Catalia, who I know we just heard from, our infectious disease specialist, presented COVID-19, The Road Ahead on Facebook Live and YouTube. We had 193 community members participated in the live event, and since then, 505 additional people accessed the presentation on one of our social media channels. On Thursday, March 18th, as part of the Women Empowering Women Support Group series, Dr. Victoria Leapart, our gynecologist, presented Making Sense of Current Nutritional Trends on Zoom. She had 26 community members attended virtually. On Tuesday, March 23rd, we had Luann Sedwesti. She is a certified diabetes nurse and education specialist, presented Managing Diabetes During Challenging Times on Facebook Live and YouTube. She had 92 community members participated in the live event, and since then, 227 additional people accessed the presentation on one of our social media channels. On Tuesday, March 30th, Dr. Michael Golden, a physiatrist with Washington Township Medical Foundation, presented Treating Neck and Back Pain from Home. Had 107 community members participated, and then since that time, 285 additional people accessed the presentation. Then also on Tuesday, March 30th, Dr. Jeff Stewart and Dr. Stephen Catalia presented Staying Healthy in 2021. The informative virtual event regarding COVID-19 was hosted by Fremont Bank. We also had, on April 1st, Lucy Hernandez, Community Outreach Manager, provided hand hygiene presentation during the Kids Breakfast Club, spring morning story time, and 47 families virtually attended. We also had, April 1st, as part of the Diabetes Matters program, they had Joyce Calixto, a registered nurse, presented continuous glucose monitors technology for better diabetes management, and we had 13 people attended. And lastly, on April 6th, Bernie Rowe, nurse practitioner, and Dr. Vandana Sharma, co-medical director of palliative care services, presented palliative care and extra layer of support. 39 people participated in the live event, and since that time, 95 additional people accessed the presentation. So I think a number of our social media and Facebook Live presentations have really been accessed by a great number of our community members. So we list them. If anybody wants to see them, you can go to www.washingtonwhhs.com/events, and you will see which ones are upcoming. So. And then just lastly, I do want to just say in terms of the charitable foundation, continues to facilitate support for COVID-19 emergency relief fund, and also through weekly meal donations and in-kind support. To date, they've helped to organize nearly 7,000 meal donations for our staff at Washington Hospital, which has truly made a tremendous difference for staff and physicians. Also, they're also putting together a lot of time into building out the foundation's planned giving program. Through our outreach efforts, many individuals in the community have expressed an interest in leaving a planned gift to the foundation, and many have already included the hospital in their estate plans. We are launching a donor recognition society known as the Legacy Society to show our appreciation for all those who have documented their intent with the foundation. And more information can be found in the upcoming foundation-focused newsletter. So, and those are the announcements that I have.
Thank you, Kimberly. Do we have any questions, concerns, or comments from the board members at this point? Okay, very good. Kimberly, do we have need for a closed session tonight?
We do not.
Very good. So it's been a very good meeting, a lot of excellent information. I appreciate all that was passed on to us. So thank you very much. And there being no further business before this board, this meeting is adjourned, and you have a good night and stay safe, and we'll see you soon. Take care.
Thank you very much.